Thank you. My name is Guillaume Chabot-Couture. I'm from the Institute for Disease Modeling in Seattle. And today I want to talk to you about some of our work related to analytics in the area of disease control and eradication, and talk about an area or part of big data that's a little bit, I think, talked less often than other two. You may or may not be familiar with one of the ways in which people determine whether a data is big or not, and it's called the 4 V's. The first one is volume. It's about the amount of data. Do you have a terabyte, a petabyte, an exabyte of data? That's a very large, very unwieldy data set, and it's as a result big. Or is your data set live? Is it streaming? Do you have some difficulties with doing the analysis related to the speed at which the data is coming in for analysis? And the last two, the two that I want to give examples of, I think are often very relevant, but not as given as much attention. And that is the question of variety of data set, different formats that are not necessarily easy to pair, or different data sets from different areas of work that you can compare and contrast to get insights from your data set that are non-obvious. And the last one, veracity, which is the little pesky part about data set, is that they're very often imperfect or incomplete. And as a result, you might want to test the veracity or the reliability of your data set to determine whether or not you should act on a specific piece of information. So those 2 V's are the areas where I want to concentrate and talk about this morning for you. And the goal is very much to find actionable insight. It's not enough to be interesting. You want to be able to act on what you find. And it's not enough to find some interesting nuggets in your data set. You want to do it at scale. Because one person looking at a computer or one example might find some interesting examples, but you want to be able to find the quote-unquote needle in the haystack. So some of the types of work that might yield some interesting insights from the variety part of big data is exploration, right? You're doing data mining, you're maybe doing some feature engineering, you're doing analyses that are outside of the typical operational analyses that a program might do. You're maybe also interested in prediction. Maybe you're trying to predict where cases of a specific disease will happen next, or where your program is having poor performance. You're trying to anticipate these outcomes using the variety of data sets that you have and combine them in an optimal way. And you might have a very large number of predictors, and you're trying to sort through all these predictors and come up with the optimal model. On the on the veracity side, like I said, you're looking to test the reliability of your data set, and that can be done in a number of ways. Maybe you want to compare 2 different data that are measuring the same underlying quantity in 2 different ways and see how they differ in what they measure. Maybe you're looking for internal consistency metrics. So if you expect your data set to behave a certain way and it doesn't, that's an indication that something's going wrong. And then third, you might be looking to use a gold standard, a benchmark to determine how maybe your very rich data set relates to a more expensive data set that's more accurate. So I want to give just 2 examples today, one from our work predicting polio outbreaks in places like Nigeria and Pakistan, and a second one looking at the accuracy of monitoring data from different sources. Before I jump in, I want to give a little bit more background about who I am and where I work, and give you a brief glance of what the Institute for Disease Modeling is. And on the screen are the different kind of groups and units within the Institute. And our goal is very much to enable and hasten disease eradication and disease control. We started in 2007 with a focus towards malaria, when there was a global call to eradicate malaria by the Gates Foundation, and grown from there to other diseases of public public health importance, as Simon outlined. For example, HIV, tuberculosis, polio, or the next set of diseases. And from there, we've expanded into pneumonia, for example, typhoid, added applied math and algorithms as a unit. And all of this work from the science side is supported by a number of software teams, professional software teams that help us build these large-scale disease simulations that unfortunately I won't be talking about today, simulate them on a very large computing cluster, and have an ecosystem of tools that allow all these research staff, these 30 researchers, to do their work. And also have a test and quality assurance team, because the software developed in-house for modeling diseases is available freely to download from our website. So since I'll be talking about polio, I thought I could give brief cliff notes for those that are less familiar about it. It's caused by polio virus, and once in a very rare time, 1 out of every 200 infections, depending on the type of polio, you can get paralyzed by it. Most of the time it's a asymmetrical paralysis of a limb, but it can also cause paralysis of breathing muscles, and as a result, death. And you may be familiar, the image on the right are these iron lungs that would enable breathing for people that had been paralyzed from polio. And on the bottom right are examples of these types of paralysis that this has caused. And the vaccines were discovered in the 50s and 60s. And in 1988, there was a global eradication campaign that started. And at the time, there were 350,000 to 600,000 cases of polio worldwide. And last year, that number was down to 74. So there were 74 cases of polio worldwide. Concentrated in 2 countries, Afghanistan and Pakistan. So it gives you an idea of the scale of the success of this program, but also the amount of time that's been required to get there. And the 2 challenges that this program faces, the ones that relate to the opportunity that I want to speak about, are in identifying the areas that have poor vaccination, that allow the virus to continue to circulate. When you're trying to find and discover areas of poor vaccination, your data sets, your traditional data sets, may not give you the information you need. So you're looking for an edge on the virus in trying to find out where next is going to be. And at the same time, when you're concentrating your efforts in a few very small areas, you're also trying to maintain the world as a polio-free area. So those are 2 kind of key challenges that program faces, where the tools of big data and the analytics that we have can be useful. So the first example is about polio in Pakistan. And on the left, you see a map of polio cases for the period of January to July. The polio cases are for 2 periods, July to December 2014 and January to August 2015. The legend there tells you that the blue triangles are the cases in the most recent period, and the empty triangles are the cases for the previous period. So it tells you a little bit about where it's distributed geographically. And you'll see very large triangles in the areas that borders Afghanistan, in the tribal areas there, where you also see a lot of red from the point of view of immunity. And that's, I wanted to show you this figure to give you an idea of what the problem is like to try to predict these outbreaks. And it's related to relating these predictors to these outcomes. The immunity that you know of and the polio cases that you're measuring. And your goal is to anticipate them so that you can fix the problems before the virus finds them. You can direct program efforts. You can do better monitoring, better vaccination, better political support to these high-risk areas where you have issues. The data that you have available to you are, disease surveillance data, survey of vaccination coverage data, maybe some operational data from your vaccination campaigns. How many doses did you distribute in Khyber, for example, or in Peshawar over the past 12 months? Maybe you have some multi-indicator cluster surveys to tell you about population and routine vaccination coverage, et cetera. A very long list that you're trying to sort and combine in an optimal way. And without going into details of how we build this model, what I can tell you is that they actually work really well. Even though these data that we use are imperfect and incomplete, they often work really well because you're able to find patterns in the data that are predictive. And so the figure on the left is how we measure our own predictive power in building these models. It's specifically showing what is called the area under the RRC curve. And I think the only thing you need to know today is that if it's around 0.5, you have no predictive power. You're about as good as random guessing. And if you're at 1, you have exact prediction. And what we're achieving is 0.9, which is typically a benchmark for good prediction. Not as good as what you would expect from a diagnostics when you're looking for 3 nines. But a 9 here is actually a good sign. And you're able to do this retrospectively. So you're building your model with historical data and you predict the next time step. And the model actually looks like the figures on the right. The top figure is the predicted risk on a color scale, and it's composed of two parts: the probability of reporting a case in blue and the predicted number of cases if you have an introduction in purple. So these models are actually the basis for prioritization in Pakistan. When we collaborate with the Pakistan Polio Eradication Program, we provide them with these models, and what they do with them is use them to prioritize the resources. They'll separate all the districts in the country in 4 tiers and determine, in the tier 1, for example, the highest risk, they will give more vaccination campaigns, more monitoring. And in the tier 4, in the lowest risk, in places like Punjab where you don't have much, you can save your resources by not distributing them there. And they do this every 6 to 12 months, depending on the epidemiology. My group has also been able to do this for other diseases and other geographies. I think the same type of approaches work really well in many other areas. For example, here on the right is a machine learning model of measles outbreak in Nigeria. And it's showing on the top where the cases have been reported in Q4 2015 compared to what the model predicted for the same period. And this was a simple random forest model with disease surveillance as the main predictor. You can also take a very large scope and look at a broad geographic area. And we've been collaborating with the global program in estimating susceptibility to polio using their global disease surveillance. And what you're seeing on the left is an example from that work where you're looking at 3 different WHO regions at the same time and trying to understand where your susceptibility to polio lies so that you can prevent outbreaks in these polio-free areas. So if I had to recap some of the lessons we've learned from doing this work over the past 5 years, I would say that it's not enough to essentially put your data in your model. You have to be able to have insights about how to engineer features in your data set. For example, one key feature that we found out from the data is that the sum of all your cases historically is a very good predictor of whether or not you'll get cases. And that's probably because it's measuring some chronic underperformance in a way that none of your other data sets are giving you insight into. And we found that to be the case for polio, but also for measles. Incorporating indicators like natural immunity or spatial-temporal proximity is also another way in which you can build these features from your indicators that you have that help your model perform better. The specific relationship between the predictors and the outcomes can change from country to country, but the approach can stay the same. So if you're looking for a pattern and your goal is prediction, that's different from making inferences. So in a place like Nigeria, your model might depend less on one type of indicator and more on another, but that's okay because your approach finds good predictive power nonetheless. And one difference is from these types of models from perhaps a expert-based model is that it tells you if something that should make sense doesn't make sense, so that you don't have to include it. For example, when we're looking at polio risk in Nigeria, we found that better sanitation was actually related to more polio risk, which makes no sense from the causal point of view. But it turned out it was mostly because there was improved sanitation around the Kano State area, which had also been an area with a lot of polio. So being careful about these relationships that you put in your model can be done and differentiate itself from other modeling approaches. And the fourth one is to be careful about noise in the predictors. If you're having sparse data sets, if you have infrequent data points, you want to be careful about the relationship between those noisy data and your outcome. Okay, changing gear a little bit, the second example I wanted to talk about is about veracity of data. What are the opportunities in looking at the reliability of the data set that you have on hand? And one example I think that's important is looking at what you get from administrative coverage data. So when you're administrating maybe a vaccination campaign, you're delivering a large number of doses to a specific target population. And if you're looking as a figure of merit of your campaign, you might use the total number of doses distributed divided by your target population as a measure of coverage. If you know that you only distributed 50% of the doses that compared to the target population, you can't have achieved that good coverage. But if you distributed 110% of the doses of the 110% of the population that you were targeting, then you don't necessarily know if you achieved 80% coverage or 100% coverage. So moving beyond these administrative data sets, using other data sets to support you could provide useful insights for your vaccination program. And in addition to this issue, you might have problems in your denominator data. You might not know your population very well. And what I want to talk about today is looking at maybe what a gold standard data set, a benchmark data, could give you in terms of insights on your imperfect data set. So here's an example. The graph on the right shows two measurements of the same underlying quantity. One from an administrative data source. So on the y-axis is your administrative 3-dose polio vaccine coverage in a specific district in Pakistan for a specific year. And on the x-axis is the same quantity inferred from disease surveillance. Okay? So when you do disease surveillance and you're looking for cases, you also ask these patients how many doses of vaccine they've received. You don't have as much data from there, but it's more accurate than your administrative data sources. And what you find out of that is there is a relationship between the two quantities, but there's a lot of scatter. And in fact, the relationship changes as a function of the range between these two data sets. So that's one of the ways in which you can get an insight about your administrative data and have a measure of internal reliability by using disease surveillance data. Looking at the same data set, you might make a map and look at where these two data sets differ significantly. And what you see, for example, on the right is that in Punjab, you have Punjab province, which is the easternmost province. You have a lot of green, right? You're getting good coverage from both data sources, so you have agreement. But in places like Balochistan, for example, which is the southwest province, you have a difference. One data set, on the right is your disease surveillance-based data set, shows you more red than your administrative coverage. So you know that you have a discrepancy there that you'd want to correct for when you're trying to analyze and interpret administrative coverage data. Now, one important part of finding outliers and trying to act on these data and these differences is to have an understanding of the uncertainty that your data have. And specifically because while your administrative data set is very precise but not necessarily accurate, conversely, your disease surveillance data set is sparse and has an intrinsic error bar. So it's more accurate but less precise. And you're trying to see what data point or outliers you want to combine these two pieces of information. And that's what the graph on the right shows, right? Each point, blue point, is your administrative data source, right? And each bar is your disease surveillance estimate. If the blue point is not within the gray bar, you know you have an outlier. You know you have a significant difference between the two. There can be a small difference, but it could be insignificant. And on the left is a map of that difference. And you'll notice that in many areas, the administrative coverage is much higher than what your disease surveillance suggests, right? You have red. But in some areas, there's actually a small difference, which is interesting. So again, if you're trying to understand what your administrative data sets tell you, or what your different very varied data sets tell you, here's one way in which you can measure reliability and intrinsic information. And before I conclude, I wanted to give two other examples, very different example of what you might do to test the internal consistency of your data set. This figure is pretty intense visually, but let's start on the right. This is a map of the growth rate of target population. Now we know that population grows about 3% per year, okay? And that's the light red, the third box color from the right on the color scale. Now for each of these district is the estimated rate of the target population year over year for these 4-year periods. So you find some areas in dark blue that have actually decreased population or target population by 20% per year over 4 years. Right? That's clearly an anomalous behavior in your data set that you'd want to investigate. Conversely, some areas appear to have grown at over 100% target population per year over a 4-year period. Another example that something is going wrong in your data set. Now, some of these may be actual very rapid growth rate around an urban population. Some of these might be adjustments when you have better data sets. But in areas, if you're trying to understand the limitation of your data set, these are ways in which you can track them. On the left is a representation of what you would expect something to be very constant based on the design of your survey and what it actually is in your data set. So what this is mapping is a survey of evidence of routine immunization. So when they go and do the survey, they report how many places did they look at that looked like they had routine immunization. And you don't expect that to change very much over time. But what the survey shows is that one survey tells you there's almost no evidence and the next one has a lot of evidence. So you know that if you're trying to look for a measure of quality, you should expect essentially these lines to be constant. So that's another way in which you can create a figure of merit for your data set, is by looking for internal consistency. So if I had to kind of sum up that second section, I would say there's a lot of insights that can be gained from comparing two different data sets. So you have variety in your data. That's great. That means you can test veracity, which are those two kind of issues with big data. And looking for concordance between two data sets is actually can tell you about the quality of both data sets. If there was no concordance, you know there'd be something wrong. And if there's a lot of concordance, that means both data sets are doing well. You could also identify outliers. You can use a gold standard data set to measure the amount of information you have. And finally, you can look for internal consistency. So in closing, I think what I'd like to say is that there's a lot of opportunities for innovation in the area of big data and analytics. And these are not necessarily always in tackling very large amounts of data, but instead in bringing multiple data pieces together and looking for comparisons and insights into data that you already have. There's a lot of data sets out there, a lot of ancillary data that you can consider when you're looking at a specific problem. We're getting better and better data sets with higher resolution for surveillance or population. There's a lot of genetic sequence data out there that I even talk about today that can be that give you a lot of insights into maybe disease provenance or movement. And finally, there are kind of interesting mathematical results that most people are not aware of that allow you to test whether or not a data has been manipulated or falsified. Humans are not very good at making random numbers up. They don't have the right frequency of digits. The first digit is most often a 1, but people don't know that. So if you're looking to find anomalies in your data sets, there's actual tools out there to help you find these issues. But there's a number of remaining challenges, I think, that we face in doing this type of work. And the first one is that a lot of health data has privacy concern, not readily accessible, and you have to establish these collaborations with these programs in order to get access and gain the trust of people that collect these very large data sets. And that, I think, is an important part of what we do. Often when you work with these groups, there's not necessarily the ideal data platform. There's not the ideal database that you might be able to connect with to do your analysis. So you might have to build these things. And finally, as we all know, I think there's a number of data quality and completeness issues that we have to surmount in order to get insight and be wary of when we relay conclusions. So I'll close here and put my colleagues up. Most likely the people that helped me put this talk together, Dr. Hill Lyons, Lena Mercer, and my colleagues from my group, and as well as our collaborators from Nigeria, Pakistan, the Global Polio Eradication Initiative, the CDC Polio team, and the Bill and Melinda Gates Foundation. Thank you.